that our definition of pulmonary ventilation is the airflow in and out of the lungs. We'll look at a more specific definition at the end of lecture, which is the amount of air into and out of the lungs in 1 minute. We won't get official about it. We have a certain volume per minute measurement. So these are factors that affect airflow. Pulmonary ventilation is a way of saying the volume of airflow. So the last time we talked about resistance, we were looking at blood flow. We were looking at factors that affect blood pressure. And so what were the factors that affected blood flow? What were the factors of peripheral resistance that affected blood flow? We see those same 3 factors affecting airflow. So viscosity, diameter, all right, so we have viscosity. Now we don't have a fluid here. Hopefully we're not breathing in 150% humidity. It is difficult to breathe when it's raining hard. It's difficult to breathe if you're underwater. But we're talking more with viscosity of pollutants, particulate matter in the air, okay? So last year about this time, we had the smoke from the campfire up in Paradise. And obviously that can cause asthmatic responses, but people who are actually in the smoke have really, not only does it push out the air, there's less air and then there's more of the particulate, okay? But it's going to bump into the walls of the airways and not move as easily as smaller gas particles. All right, then there was the diameter or radii, which is half the diameter, but now we're not talking about blood vessels, we're talking about airways, all right? So diameter or radii, which is half of a, but of which airway? Remember from Tuesday's lecture, what specific airway were bronchioles? It rhymes with arterial, which is our most effective airway for changing resistance or blood flow. So because, anybody remember why it's bronchiolar diameter that is most effective in changing resistance? Right, there's no cartilage, so they can constrict or dilate more. And there's a lot of them. So we have more of the bronchioles than we do of the bronchi. We have even more alveolar ducts, but they don't have enough of the smooth muscle to do much constriction or dilation. Remember the innervation. So when we were talking about blood flow, sympathetic nervous system did both constriction and dilation of our blood vessels, except in the reproductive system. When we're talking about the airway, it's not. It's a combined component. So sympathetic is going to dilate the airways by binding to beta-2 receptors. And parasympathetic is going to constrict the airways, binding to our typical muscarinic receptors. So not a lot, but some of the nerve gas poisons affect acetylcholinesterase. All right? So if there's not enough, if the acetylcholinesterase is not working, are we going to get too much acetylcholine or not enough? Too much. So the problem with that is the acetylcholine is going to bind to these receptors and cause constriction of the airways. But what else is acetylcholine going to bind to that affects the respiratory system? What do we talk about at the very beginning? The muscles. So our skeletal muscles also use acetylcholine. So those go into spasm, all right? And then you can't do the pulmonary ventilation. So not only is it affecting pulmonary ventilation, but it's affecting the diameter, constricting the diameter of the airways. So that's one of the way sarin gas works. So the poisonous gases. All right, so we have viscosity, diameter of the airways, and what was the last one? Length. So we had length of blood vessels, and we said the quickest way to change that was to have an amputation. You can't grow blood vessels very fast, all right? For airways, you can reduce them by having a lobe removed, but that's a rather drastic way to affect decreased airflow resistance. It's not going to really help your breathing at all. So primarily we increase airflow, we increase the length by using something like this, putting somebody on a ventilator, okay? However, that usually has a pump associated with it. So one way that you can look at two of these, diameter and length, I would suggest you change the viscosity. Use a straw and close your nose and try to breathe through the straw for a while. Even if it's the large diameter from Panera's, which I hate drinking their frozen mochas with that because I like to take a little sip at a time, not gong, just inhale it. I don't know if they want you to buy more or what, but so that smaller diameter of a straw that you're breathing through, plus the added length, all right, will give you a feeling of air hunger because you're just not going to be able to get in as much air and get it out enough to provide the airflow that you need. So that's our airway resistance, and I have some images for that, okay? So smog, the ventilator tube, and resistance increases as we move to smaller and smaller airways. All right, so here's sympathetics, going to do dilation. Parasympathetics, going to do constriction. Now, the next one is the term compliance. Both my boys worked at my husband's business for summer jobs, which is a nonprofit association that builds affordable housing. And he's CFO, but he often gets summer jobs. And they work in compliance. So for that job, compliance meant making sure that any applications or financial portfolios met rules and regulations for the state and federal government. So you're in compliance, you're following all the rules. That's not what we need here, all right? Back to the rubber band that we talked about for the Starling Frank Law when we were talking about the heart. Compliance, you can see it if you want to pump air into the lungs. Compliance is the ease with which the lung expands. So we have the alveoli that have surface tension, all right? Increased surface tension within the alveoli is going to decrease compliance. We have to break all of those hydrogen bonds. The newborn, taking its first breath, is going to have lower compliance than after it's taken its first breath and it has surfactant, it's broken all those hydrogen bonds. Now, if it's a preemie, or it has a condition that hasn't allowed it to produce the surfactant, it's had the respiratory distress syndrome, then it's going to have low compliance. It's going to have a difficult time expanding the lungs, all right? Now, the pneumothorax we talked about, we're going to create an artificial pneumothorax with the sheet lung, and as air builds up in the pleural cavity, it's going to be difficult for the lungs to expand to fill into that because of the compressed air around it. That's an unusual form of compliance. And then pulmonary fibrosis, an increase in the amount of collagen in the connective tissue around the alveoli makes that tissue more solid. And so that's what we see down here. So it decreases compliance. Now, why would emphysema have very high compliance? It's too easy for people who have emphysema to expand their lungs. The difficulty is in moving their air out. When we look at some of these conditions, when we look at our pulmonary function tests, and we'll do a little bit more next week as well. So if we look at the normal pattern of normal alveoli, remember there's pores that the air has to pass through. We have a lot of surface area because it's between the walls here and the blood vessels where we're having gas exchange. And then the mechanism of disease for emphysema, these walls break down. So we end up with a space like that, all right? So not much structural support, they're very floppy, and it's very easy for those to expand, okay? So emphysema has high compliance because we've lost the walls that would make it difficult to stretch. So that's compliance. So high compliance means easy to expand. Low compliance means stiff, okay? So you've all probably tried to blow up those balloons that you make animals out of. Those are hard to blow up. you have to use a lot of your active expiratory muscles to do so, all right? But some balloons are pretty easy. So the ones that stretch really quickly, you don't have to pass out trying to blow them up, would be the high compliance. You just can't get that balloon to expand no matter how hard you push air into it. That would be a low compliant balloon, okay? All right, so the surface tension, if there's a lot of surface tension, that's going to affect compliance. It's going to make it difficult to, so we have to lower that surface tension with surfactants. So those two are, are closer to each other. So surfactant increases compliance because it reduces surface tension, okay? I think that links back to the newborn with the respiratory distress syndrome having low compliance. All right, so what's the difference between elasticity and compliance? They're opposite sides of the same coin. So compliance is the ability to stretch. High compliance stretches easily. Elasticity is the recoil aspect of that. All right? So when we do the pumping of the sheet plug over here, there were some cuts, so I had to pinch it off. And you'll see this a little bit better. So I'm pushing air in. The resistance to me pushing the air in is compliance. When I let go and the recoil of that tissue back to return to this position, I wouldn't say normal because it's not the way it would be inside the actual sheet lung. That return to its normal position would be the recoil, primarily because of elastic fibers. In this case, there is probably surface tension too, okay, because who knows what happens to the surfactant after the sheet is filled. There'd be an increase in surface tension. So that return back is the recoil, the elasticity, okay? All right, so the last thing next to the last, we're going to talk about pulmonary function tests, and then we're going to just describe pulmonary ventilation versus alveolar ventilation. So, may I erase the board? Got that. So, this is not really a machine, it's an apparatus. It's shown in the lower left. Respiratory therapists do this with patients in the hospital a lot before surgery. They've got little tubes that they have them breathe in to exercise their lungs so they can get rid of the drugs and anesthetic and so on after surgery. So this is called a spirometer, a dry spirometer. When I first started teaching, we had wet spirometers, which were a box without a lid. So a box like this that was upside down, and it would fit in another box that was this way, but it would fit into it that was halfway filled with water. And then this would be put over it. When students blew into the tube, it would fill this box up water. There'd be air between the water and this box, and it would rise, and that would cause a marker to rise on a component. But with all that water and different people blowing into it, it became a site of bacteria and growth and stuff. And so we have these. You're still blowing into them, but they have filters, and we change mouthpieces. We don't suck in. You're not rebreathing that back in. So this only measures expiration, not inspiration. So it has limitations. And the first measurement is at 1,000. Okay? So there's nothing from 0 to 1,000. To look at our first, and I'm going to be a bit before I actually use it. So when we look at our first measurement of pulmonary volume, it's tidal volume. So we breathe in and we breathe out. And we breathe in and we breathe out. Usually about the rate of 12 times a minute. Okay? So in last night's class, I stayed home with my granddaughter on Tuesday. Actually, I picked her up from daycare because she had thrown up. And so I'm counting her respiration rates. She slept for like 6 hours. respiration rates were 44. So I have no idea what a 10-month-old's respiration rates would be, so I Googled it. And it said, you should call 911 if a 10-month-old's respiration rates are over 60. So like, okay, we're 2/3 of the way there, so we should be okay. And today they were like 20. So it's called tidal volume because like the ocean tides, the tide goes out, the tide comes in. Tidal volume is one or the other. It's either the inspiration or the expiration. And as you remember with the heart rate, we should have the same amount of air going out as we have coming in. Because you have less air coming out, that's the difficulty with asthmatics and emphysema, we get increased amounts of air left over in the lung. So tidal volume is the normal breath, and the average, which is hard to define, is 500 mils. Why does that vary? I didn't make that comment when I said that average stroke volume was 70. You go to check somebody's tidal volume, what's the first thing they do? You want to count their respiratory rate, what's the first thing they do? They slow down or speed up because they know they're being counted and they start thinking about it. And that's referring back to what we said a few minutes ago. Breathing is a voluntary skeletal muscle. We normally don't think about it, but you can slow down, you can stop. We'll see how long you can stop next week without passing out. No hyperventilating first. And so what I used to do when I was working as an RN, I was taking somebody's pulse, I put my hand on their back and then count their pulse for 30 seconds and then keep holding their wrist and then count the respirations for the other 30 seconds without letting them know that's what I was doing, so they wouldn't just, oh, I'm thinking, should I take a breath now? Maybe I should wait, or that type of thing. So this is going to be variable. To measure it on this machine, you have to move the little pointer over to 1,000 because you're not going to, each little mark is 100. So you have to subtract 1,000 from what you actually end up with. So I'm just going to take what I think is a normal breath, but that's what I'm thinking now that I'm thinking about it, instead of just putting it in there and breathing. All right, so. And it was 100. Last night I think it was 250 the first time. And that, is that my normal breath, or is that the machine not measuring what? Yes, who knows? And that was 400. So you can change it. So we usually do it on an average type of thing when we measure these. Now what we're actually going to be doing for measurement on Tuesday is, like I said, we have a calibrated large syringe, and you breathe in and out 5 times. The machine calibrates that and then kind of bases subsequent measurements on that. So 500 mils is average, but you can make yours 200, or you can make yours 750. Okay, you'll see that variation next week. Then, after you breathe in the normal amount, and who knows what that is, so we'll just say you take it as deep a breath as you can. I don't know why you go up your tippy toes, but it seems to make your airways bigger. I'm trying to lift my ribs up as much as I can, use my accessory respiratory muscles, lower my diaphragm. So when I do that, let me give myself a little bit of room here. And that amount over and above is identified as my inspiratory reserve. So what I can breathe in above what my normal breathing in is. Now, I can't measure that on this machine because I have to use this apparatus to blow out, all right? So inspiratory reserve is usually around, depending on male, female, 2,500 to 3,000, okay? I'm not going to ask for these specific numbers because they vary from, I just want you to identify them on a chart like this and know which ones change with which diseases. All right, so how do we measure inspiratory reserve if you can only breathe out on this? Well, now that you've breathed in as much as you can and you're holding your breath waiting for me to tell you what to do with it, breathe out as much as you can. That's usually about 1,200 there, 1,000 to 1,200. The difference from what you normally breathe out and what you can force out is expiratory reserve. Okay? Now you can measure that. Little variable. Just breathe in passively. Breathe out passively. Doesn't matter how much you breathe in. Breathe out passively, the sigh I talked about earlier this evening. And then put your mouth over this and force the rest of it out when you're actively using expiratory muscles. Okay? Oh shoot, I did it last night too. Forgot to reset it to 0. Mine probably won't even read. I'll set it on 1,000. Just remind me to take off 1,000. Okay. I'm still alive. But that's why I moved it to 1,000. But active expiration, okay, is expiratory reserve. That would be from here to here. When we add those up together, we get vital capacity. Vital capacity, sometimes called forced vital capacity, but whether it's vital capacity or forced vital capacity, the volumes will be the same. So vital capacity is equal to the sum of inspiratory reserve plus tidal volume plus expiratory reserve. Okay? Now remember, we can only do inspiratory reserve by inspiring. I suppose you could breathe out until it felt comfortable, but that would just get you to the top. So I can measure my vital capacity, so I can figure out inspiratory reserve is equal to vital capacity minus the sum of tidal volume plus expiratory reserve. Does that make sense? So I can figure this out. I can figure this out if I take out this and this. Because I can figure those out by blowing out. So once I take that and that from here, then I'm left with inspiratory reserve. I'm going to measure my vital capacity. Vital capacity is given in your textbook as, I read it up here. This one says for females 4,200, but in the book it says 4,800 because for males it says 6,000. Vital capacity, females 4,200. If you just read a chart, it doesn't separate by sex, then it's 4,800. Okay? So I'm not going to get over 3,000. I think last night I got 23. But it changes with your height and your age. Okay? So stretch out those alveoli, pop those visceral pleura. Well, I was 1,000 less than I was. I got to 1,200. I think I was 22 or something last night. Must be the machine. So, I'm going to show you something. Because these are charts that adjust your vital capacity based on your age and your height. All right? So, I'm 5'10", and this is in centimeters, so you have to multiply your number of inches by centimeters. And I come out to like 177 point something, so 178 an age. I'll be 62 in December. So my vital capacity is supposed to be 33,600. I was a third of that. All right, so remember I said the textbooks they don't separate by gender, go, say, 4,800. So the best projected vital capacity for a female is a 16-year-old who is 6'4". And her vital capacity should be 5,000. Okay? Oh, that was males.
Okay.
All right. That was a bit high for me, so let's do this again on for me. So for my height, I'm supposed to be 2,800. Last night I was 23. All right, so 16-year-old female who's 6'4", her vital capacity is 3,920. About 1,000 off from that 4,800, right? No female on this chart is 4,800. Not even 4,200, much less 4,800. All right. So the number of males that are whose vital capacity is supposed to be 4,800. That starts with a 16-year-old who is about 6 feet. So basically, this little corner right here are the only males by age and height. So the youngest and tallest, this little corner right here. So nobody older than 26 at 6'4" has a vital capacity that's supposed to be 4,800 or higher. And yet, for as long as I've been teaching, since 1981, that's been the published vital capacity average for population. So I decided that they must have gotten those numbers from a bunch of Coast Guard applicants that have been swimming all summer underwater. They have to swim the length of a Olympic-sized pool underwater without taking a breath because nobody else. Now that's not an average. Now I've had a few guys get to 6,000. Guess what they had in common? They were swimmers. Okay, that's why I said Coast Guard, because you have to pass the swimming test with that. So we just everybody just tends to republish and republish and republish, and who knows where that data first came from. All right, but it also I think East, not West Indies, but East for people from India also have lower vital capacities expectations, and like I said, height and age. So best thing to increase your functional capacity, running helps, anything that's cardiovascular, but swimming, okay? Was a really good one for that. All right, so these are your basic volumes. In addition to that, we have a couple more. After you've blown out, exhale as much air as you can exhale. There's another liter or so, about 1,000 to 1,200 mils left in your airway, known as residual volume. Only way to figure that out is to fill your lungs up with water and pour it out and measure it. Nobody's willing to do that. So this is close to what I talked about on Tuesday night as anatomical dead space. So you're never going to get your airways to actually collapse. All right, so that component is what we see with residual volume. Now, there are certain diseases in which some of these change. What common respiratory problem is going to cause an increase in residual volume? Yeah. And emphysema is a form of COPD, chronic obstructive pulmonary disease. All right? So, we see a change in residual volume. Those individuals that have asthma, chronic asthma, not just occasional acute problem, emphysema, and some just long-term pulmonary problems that just get lumped into, you have COPD, which is not really an actual disease, but issues with airflow. A lot of different other diseases contribute to it. They have difficulty moving air out of the lungs because of destruction of alveolar walls or narrowed airways. Emphysema and asthma patients have, asthma patients especially have narrowed airways. So when you're trying to move air out and it's not moving very well, you have to move it out so you can breathe fresh air in, right? So what do we tend to do if it's hard to move air out? We squeeze the pump. What does that do to the tube? It squeezes the tube too. So it kind of compounds the problem. Your tubes are already narrow. because of muscle constriction and excess mucus like asthma individuals have, and then you squeeze the lungs, the chest wall, trying to push more out, you're also squeezing those bronchioles. The bronchi have a cartilage, so they're a little bit protected, but the bronchioles are going to get squeezed smaller too, and that just exacerbates the problem, okay? So over time, these individuals tend to increase their residual volume over average. Another pulmonary function test that changes is the ratio of how much air, so your total capacity, how much of your total vital capacity can you breathe out in 1 second? So it's called FEV1 over FVC. FVC is your total volume. But it doesn't matter how long it takes you to breathe this. Like I said, FVC and VC are the same value. Okay? So may I erase this part of the board and I'll illustrate how this is done. And this is the reason I like our BioPack so much better than the spirometer, because we can do this on the BioPack. Okay? Now, it doesn't always come out accurate. I've seen some individuals give me a FEV1 ratio of 60% and they don't have obstructive pulmonary disease. So the ideal, often the range is given between 80% and 84%, but we'll stick with 80%. So you should be able to breathe out 80% of the maximum air that you can breathe out in 1 second, all right? So you take in as much air as you can, and the machine's going to hold a straight line while you sit for a second, and then you blow it out as fast as you can. All right? So this bottom line right here, the difference from here to here, is your vital capacity. Okay? Because you are blowing out as fast as you can, it's your forced vital capacity, so they're going to be equal. Doesn't matter if you take 5 minutes to blow it all out, it's still your vital capacity. And then we start a timer. And at 1 second, we measure how much of that air have you blown out at 1 second. Okay? So if your vital capacity is 4,000 mils, and at 1 second you've blown out 3,000, then your F, forced expiratory volume at 1 second, okay, your FEV1, FVC ratio, this is always given in percentiles, is going to be 75%. So to have normal FEV1 ratio, it should be 80% or higher. Okay? So those are two key signs, the increased residual volume and a low FEV1 ratio are two specific signs for obstructive pulmonary disease. So decreased FEV1 and increased residual volume. Okay? Let me draw you a little diagram because the terms obstructive and restrictive can be difficult to keep straight. So obstructive obviously would be chronic obstructive pulmonary disease. Asthma, emphysema, conditions that cause the air, so here would be a normal airway and a normal lung volume, okay, a residual volume, alveolar volume. Obstructive pulmonary disease is going to have a narrow airway, all right, and that's not very large, but a larger alveolar space. Restrictive pulmonary disease, this is where there's less volume available. So maybe you're going to have a normal airway, and you're going to have a loss of alveolar volume, either due to fluid, such as pulmonary edema, or pneumonia, or cancer that's blocked off some of the lobes, all right? Lung or bronchial cancer. Even tuberculosis, because the tuberculosis bacillus in the lung trying to heal itself will close off certain regions and encase it, and that means that area is not accessible for airflow, all right? So think of cutting off regions of the lung to which air can get to. Okay? So for that, we have a decreased overall of everything. The FEV1 can be normal, but your overall vital capacity is less because we've actually lost parts of our access to alveoli. Either because the alveoli are filled with fluid, or they've been gone due to disease, or blocked off from a tumor, okay? So loss of volume is the key sign of restrictive pulmonary diseases. Yes, because you got whole lung collapse. Okay, so, where am I missing my terminology here? All right, we'll just put up what the word. So the last thing we're going to talk about is the difference between pulmonary ventilation and alveolar ventilation. So we've been talking about pulmonary ventilation most of the evening once we got past the lung tissue, and that's air moving in and out of the lung. So we can measure that in milliliters. Just like we measured blood flow, okay? So we're going to do tidal volume, because it's the pulmonary ventilation is going to be the air that moves into and out of the lungs in 1 minute. So what do you think we need to do to measure that? Pulmonary ventilation is the air, total air that moves into or out. We're not summing it up, it's either or. Volume of blood that moved out of the heart in 1 minute. How do we figure out cardiac output? Heart rate times stroke volume. All right, and we got mils per minute. So what's going to be the equivalent of heart rate? Respiratory rate. So respiratory rate. And what's the equivalent of stroke volume? Tidal volume. Yeah, tidal volume. All right, so respiratory rate is typically 12 is our average. Tidal volume is typically 500. So that gives us a pulmonary ventilation of 6,000 mils per minute. But we don't stop there, because not all of that air is actually in our alveoli. Remember I used the term anatomical dead space Tuesday night? That was the volume of our nasal cavity, our pharynx, our trachea, our larynx, our bronchi, everything before we got to any alveoli. So although it varies from person to person, anatomical dead space, we're going to assume for everybody is 150 mils. So for tidal volume, to get alveolar ventilation rate, we have to subtract 150 mils from every breath volume. So alveolar ventilation is going to equal 12 times 500 minus 150, which is 350. So 12 times 350, which I think from last night came out to 4,200.
We do the minus 150 for everybody?
Yeah, so for whatever the breath volume is.
Oh, okay.
And from every breath that you take, for each breath, no matter what it is, if your breath is 800 mils, you're going to have to subtract 150 to get what actually gets down into the alveoli.
Okay.
Which brings me to my next point. Let's say your breath rate, your tidal volume, like mine was only 300. And I subtract 150 from that. I'm only getting 150 mils of air into my alveoli. So I'm going to have to breathe pretty rapidly to get a good alveolar ventilation. What if my tidal volume was 800? Then out of 800, 650 mils was actually getting into my alveoli, and I wouldn't have to breathe nearly as rapidly, but I'd have to breathe more deeply. So fewer breaths, but deeper is a more efficient way of oxygenating our lungs and getting rid of the CO2 when we breathe out, okay? In fact, I could pant and not get any air to my alveoli at all. I'm just moving up and down from my larynx and out, okay? So I'm, breathing in 150, but all of that is going into my anatomical dead space.
So like someone with pneumonia, their dead space would be much higher possibly?
Well, their overall vital capacity would be lower,
Right.
and a greater proportion of that.
So we still use the same.
Yeah, but it's just, so let's say they're just getting, so let's say they breathe in 500, they're still getting 350 down to that area, but it's not all going out to where it could go. So they're probably not even able to take in that much, like filling in a cup of water, but it overflows. All right, so I think you have in your lecture notes a table that compares various respiratory rates and various breath volumes. And you can take very few breaths if you take deep volumes. So slow, deep breaths are going to be much more effective in getting an oxygenation down to the tissues. Okay, so people that are panicking or scared tend to increase their respiratory rates, and they're just not, or even if they're sick and they have a fever, they're just not getting as good an oxygenation tissue if they do that rapid shallow breathing. All right, so we're going to stop there. Tuesday when we come back, you will have completed your exam. You won't have to split your brain on what you're thinking about. And we will look at the gas exchange, so we're going to move into the alveoli and look at how what gases dissolve into the blood and how we transport it. What factors that we've already discussed increase or decrease the diffusion distance, and the chemistry of how oxygen is transported on hemoglobin or carbon dioxide. Okay? So if you want a quick bathroom break, go ahead and I'll start the sheet plug demo probably about 5 till. Okay? That's going to consist of is you and I, number one, pumping the ambu bag and moving air into the sheep lung. The resistance that you feel for that would be what? Of the currents we talked about. But the difficulty or ease of moving air into the lung. Compliance. So we've certainly affected resistance with the length of the tube and so on, but in pushing that air in there, that wanting to stretch or not stretch is compliance. Once you've had a chance to do that, I'm going to pull the plastic bag up. That will be our parietal flora. I'll slash the lung or just open it up where it's already been cut. It will create an artificial pneumothorax. Okay? And then anybody that wants to, I would suggest cutting open the trachea. You can see where it divides into the right and left bronchi. Certainly while it's being expanded, you can feel the lung tissue itself. So if you have gloves, I have a few extra. You can put those on, okay? Or if you want to dissect more of it, I'll show you. We also have heart and liver tissue with this. So I want you guys, we'll do that in about 5 minutes. Okay?